Welcome to today's IDRPP's Time to Act Substance Use Echo. I'm Leo, the project assistant here for Project Echo up at the Institute at Utah State University. And if you could please just drop your name and your contact information in the chat, it'd be greatly appreciated. This just really helps us network with each other and helps us contact one another if we have an idea or resource we want to share with each other. And if closed captions do make the session easier to follow, you may go to the More button on that toolbar at the bottom of your screen and you can toggle them on. And then we are recording today's session for educational and quality improvement purposes. So when joining and participating in this session, you are consenting to being recorded. So if you don't wish to be recorded, you can disconnect from the call now, but we do really want you here, so don't disconnect. And Echo is an interactive community. We have our presenters, stakeholders, and community members engaging with one another, whether it be sharing resources or giving recommendations on a case. And participants are expected to be engaged in asking questions either after the didactic presentation. You're also welcome to drop those questions in the chat and we can get those answered. Case narratives and case discussions are really just a great way to get support on any difficult case that you may have. And we can apply those strategies from our echo sessions to real world problems. So if you haven't presented a case narrative yet, please consider doing so, and you can contact Project Scope at usu.edu to present a case. We do work with sensitive topics, so please take a moment to de-identify those situations. And if you are unsure about a statement or a question, you can always reach out to one of our hub members, who should all have asterisks by their name. The hub member monitoring today's chat is Janelle Preston, so she can address any of those comments, concerns, or questions that you may have. And also, we have three key components to today's echo session. The first is our subject matter expert. So for today, we're having Jasmine Charles present on perinatal substance use disorder and maternal health. And our second key component is our case presentation, which Janelle Preston has prepared for us today. And our last component is professional networking, which can happen in our breakout rooms or by reaching out to someone in chat. Echo sessions are really just a great way to network with others from similar organizations and get really great ideas. And also, please remember again to rename your profile to your first and last name, your state, and your organization. If you don't know how to do that, you can click on the Participants tab in the bottom toolbar. You hover over your name and you select Rename when clicking those three little dots next to Unmute. And the raising hand function is just really helpful if you don't want to interrupt the presenter or the person who's speaking in a breakout room. You can raise your hand and maybe make a comment or ask a question. And it's just a great function to use, and it's in the React tab now. And just to go over some quick etiquette in our echo sessions, just remember to please respect the presenter by using chat or raising hands to contribute when the presenter is speaking. Also, please remember to mute when you're not speaking to just respect the participants and the presenter's time. Let's also keep our questions brief and on topic, as it really helps everyone get into the conversation. It really also assures that we give our full attention and time to our presenter. And if you could please introduce yourself and your organization before asking a question, that would be greatly appreciated. And last, we always encourage our participants to turn their cameras on. It really just helps us connect and build community over this virtual echo session. And for today, Tori will be dropping the survey link to get that credit of attendance, and that credit is presented in the form of a certificate of attendance. We really do value your feedback, and we always use those survey results to improve the quality of our echo sessions. It lets us know how we can help you better. So we also have a place in our survey that asks for an email, phone number, and mailing address, and that's just so we can send you some free swag. So if you attend enough sessions, you might be getting a free little gift from us in the coming future. And Canvas is just a platform we use to put resources from today's session and past sessions for you to access. If you'd like an invite to our Canvas page, you can always email projectscope@usu.edu and we can get that invite sent over. And here's just another plug for case studies. It's a really great opportunity to just receive valuable and applicable feedback. And if you're interested in presenting a case study, or if you'd like one of our team members to present a case study for you, you can email projectscope@usu.edu and we can get that set up. And also, please follow us on our social media pages. We post updates, reminders, and we also post information from sessions, some impactful quotes as well. So these pages are just a good way to stay connected with one another. And if you'd like to, you can join our Facebook group by scanning that QR code, where you can also receive some updates about what's going on with Echo and some future reminders for session. So I'll hand the time over now to Jasmine.
Thanks so much, Leo, and thank you all for being willing to share your lunch hour. I know that our lives are full of valuable time that we can't get back, and nor do we have enough of. I'm going to share my screen so you've got access to my slides, and you can see what we're going to talk about today. Ultimately, my friends, this is going to drive the rate that you would like it to drive. So if you have lots of questions in a certain spot, that's where we're going to stop and talk about it. As Leo said, my name is Jasmine Charles. I am a PA by licensure and have practiced for almost 14 years. I'm the co-founder and clinical director of a clinic that is known as SuperAD, which is the Substance Use and Pregnancy Recovery Addiction Dependence Clinic. Those of you on this echo session likely have crossed paths with one of us at some point in time. Dr. Marcella Smid is our medical director and my co-founder. And then we have a team now that's built of about 25 individuals who work. We are an integrated specialty prenatal clinic. We take care of individuals with the focus of pregnancy and a year postpartum who identify as having a substance use disorder or having had a substance use disorder or struggling with chronic pain and on medications that might increase risk for neonatal opioid withdrawal syndrome. We are a one-stop shop. We've got social work, peer support, your ultrasounds, your blood draws, your link to community connections are all done in one location. And we both physically as well as psychologically meet people where they're at. So we also really encourage harm reduction, and you're not turned away from the clinic no matter what's going on in your life. And today I've been asked to come and talk to you just a little bit about what we do, which is ultimately taking care of individuals with substance use and pregnancy. We're going to talk about the myths, the legends, and some evidence-informed truth. And we use evidence-informed because, unfortunately, medical research in the realm of pregnancy in particular, but then if you put substance use disorder together with it, is very minimal. And so there's a lot of upcoming information. There's a lot of articles out there if you Google it, but a lot of it is very minimal numbers. And so we do a lot of informing and talking about what we know. We are a team that is four-pillared. And we work in the direct patient care arm. We also work in a research arm. We work in an education arm and an advocacy arm. And throughout talking to you today about substance use disorders and pregnancy, hopefully you'll see a little bit of all that. This photo here, where I'm going to give you my disclosures because I have to, because we're at an echo session, was taken last March. We are very fortunate to be one of the largest recipients of opioid settlement money in the state of Utah and the Salt Lake County greater region. And we were able to open the clinic that I am working in today, which is in the Rose Park area. So we work out in South Jordan physically one day a week. So the south end of the Salt Lake Valley. We work at the main university hospital one day a week. And now we are very fortunate to be here on North Temple. And today is honestly my favorite day of the month because we spend our afternoon with a walking clinic working with two of our street outreach teams who bring in women who may need sexually transmitted infection screening as well as access to contraceptive care and health care. And we provide that service. So things you need to know about me. I do have some funding from Gilead Science. I'm a medical consultant for them, and then they fund one of the trials that we run for treating hepatitis C in pregnancy. I'm also a member of the Speaker Bureau for Braeburn, which is a pharmaceutical company that has created one of the long-acting injectable medications to help us treat opioid use disorder. I'm also the training director for Elevate. We are one of the 7 maternal centers of excellence funded by the NIH in this country. We are working to reduce morbidity and mortality. And then I'm the clinical director of the clinic you're going to hear about today. So I am partial to our clinic, and then I'm also a medical clinician as well as a research clinician. Who am I? More importantly, in my mind, is where I come from in my background. Like I said, I am a PA, and I am very proud to be a PA. We are a multidisciplinary team of midwives, nurse practitioners, PAs, and doctors. So we do span the whole medical field, being able to provide cradle to grave care. I am a family practitioner at heart and do take care of our pediatric patients with the pediatrician we have on service that takes care of the babies born to our mamas as well as their other children. And then I also practice primarily here running our team. I'm also a mom myself of a beautiful adopted daughter who's now 22 years old. I'm a wife and I am Latina, so raised in a household speaking Spanish and English. Let's talk a little bit today about defining and understanding substance use and the substance use disorder definition itself. Let's talk about sex and gender and substance use, because that's a big deal of what we do here, working specifically with, as we like to say in our clinic, people who don't have dangly bits. And then the evidence-based models of care for pregnant and postpartum women with substance use disorders. Utah State is my undergraduate alma mater. I love you all and know you well. But we also, unfortunately, for us here at the University of Utah, we are the monopoly of teams. We really are. We're the first in the greater Intermountain region that's providing this care. And so for those of you up north, a lot of times we are also your catchment to be your support, and we are happy to do that. The biggest thing for me, and honestly, I usually have my amazing care coordinator, Shauna Filion, who is in long-term recovery, who carries what we call our bat phone and works with our patients one-on-one over the cell phone and answers our crisis calls, do this piece, but it's all in what you say and how you say it. So substance use disorder for a lot of us can give us a really uncomfortable feeling. And what I like you to do as we do go through this talk is sit with, how you feel about that phrase. For a lot of people in society, it's defined as a moral failure where it's ultimately a chronic illness. And so we have definitions of what substance use is. We have definitions of what substance misuse is. Use is that sporadic consumption without adverse consequences, whereas misuse is that excessive use of psychoactive substances such as alcohol, pain medication, or any illegal or illicit drugs, potentially leading to physical, social, or emotional harm. And so when we say substance use disorders, we are helping to talk about a disease rather than a societal failure. People can have a tolerance. This happens in a lot of different cases. They can have that physiological adaptation and diminished response to a substance after repeated use. This happens to my patients who are, on long-term antidepressants. Our medication doesn't work as well as our body becomes tolerant to it. This can happen if we have repeated headaches or back pain and use ibuprofen every day. You can have a physical dependence. That's that actual adaptation or manifestation where you can have withdrawal. So that's, I have used Afrin to make my nose not so stuffy for days, and I stop using it, and I have withdrawal from it, which is actually a rebound of the stuffiness. The same can happen with illicit substances. The same can happen with prescription opiates. And then there's also that piece of psychological dependence, that sense of, and that feeling of a need for a specific substance. So let's talk specifically about the word addiction. It is a disease and a disorder of the brain specifically, okay? And it's all part of our reward, motivation, memory, and related circuitry. And 50% is hereditary or familial. Many of you may have questions about that. Unfortunately, none of us can really answer that question. We've not quite stemmed to how the hereditary or familial aspect works from generation to generation. You could say it's back to that kind of nature nurture piece of things, but we know there are individuals who are born from a family who had a history of substance use disorders, who are raised by a completely different family and maybe not had that nurturing exposure to substance use disorders, who are still prone to them in their adolescent and young adult years. And ultimately, what we've got is a dysfunction of your circuits. Your brain circuits are not talking to each other correctly. So this can be really scientific and really higher level, but what I ask you to do to kind of help understand it, and it also helps me be able to explain to families and patients to understand it, is to think about dopamine, because we all hear about dopamine. And honestly, most of us have probably watched Inside Out, the feelings movie now. So I always talk about all those little feelings that are on the screen and bouncing around, and we can turn them on with a circuit of pushing a button. Dopamine is the chemical in our brain that makes us happy and drives our happiness circuit. And so every day, our dopamine goes up and down throughout the day based on things that make us happy. So for most of us, when we wake up in the morning, our dopamine is probably pretty average, if not a little bit low, because most of us wake up tired and feeling like, whew, I got to do another day. Maybe our coffee, our breakfast, going to the gym, whatever it is, our kids waking up and being happy to see us, unless you have teenagers and they're not always happy to see us, but whatever gets that day going that makes you have that first smile of the day, that is your dopamine. So your dopamine is this little bouncy ball through the day, right? We realize towards the end of the day that we only have an hour or two left till we get to go home, dopamine. Currently, as much as all of us hate daylight savings time, usually looking out the window when we get to go out to our car at 4 or 5 o'clock in the afternoon, dopamine, because we still have daylight. And I'm going to ask you to think about moments in your life where you have the highest levels of dopamine. For some of us, it's the day maybe that we had children or the day we got married. It may be this incredible vacation you got to take at some point in time, or any vacation where you had some time off or some free time. It may be the day you got into school or received the degree that you've worked towards. And that is the highest spike of your dopamine. And I use vacation as the example because that's what most of us think on a regular basis. We are working towards the next time we get to go on some amazing trip. And that is us trying to get back to the highest level of dopamine we've ever had. The first time an individual uses a substance, primarily with methamphetamines, it actually works even more so, but opiates are similar. The dopamine spike that happens with the use of that substance for many individuals is up to 100 times higher than the highest level of dopamine you've ever felt in your life. And so if you think about how every day we are chasing the happiness, and hopefully most of us have happiness every day, but we love that feeling of dopamine. When an individual uses a substance and then they're withdrawing from that substance, many people say they're chasing a high or just stop because you could stop using. That's not the case. You actually don't feel well as that dopamine drops because you are losing the happiness and the drive for life. And I spend a lot of time with patients and their families, their caregivers, whoever is coming to us that the patient wants us to talk with about dopamine, because for me, it helps me to really understand. I'll never be in those shoes. I will openly and usually in my disclosure let you know I am not somebody with a history of a substance use disorder. I have many team members who are lived experience, and they're the ones who are actually helping people figure out how to love themselves and regain their lives and manage this disease. I am privileged enough to have gotten a medical degree, and I am privileged enough to have been given the chance to open the doors to let people come in the door for a safe space where we will love them until they can figure out how to love themselves. But if I can remember what it's like to chase my dopamine on my days that are really hard, it helps me to remember what my patients are facing. So if you leave me today with one thing, I'm going to really honestly ask you to just leave me with the fact to help me get rid of this statement in society. This is one of those triggers that gets put out there that babies are addicted at birth, addicted babies, poor babies, all these babies. Like we talked about earlier, addiction is a disease of the brain where you actually have to have the channels change. Babies don't come out addicted. It's not even physiologically possible. They can come out exposed to an illicit substance or a prescription. We're going to talk about that a little more later as well. And they can come out with some risk for withdrawal. But these media alerts we see and hear regularly are incorrect. And I always have you think through what can you do? Because some of us do big things with substance use every day, like I do, where I'm running this world of a clinic. And some of us are looking for the tiny things that we can grasp at. I honestly will tell you that I think the most important thing that I do is the advocacy piece of the arm of what we do. And advocacy sometimes looks like me just simply plopping a comment in the comment section of this news article that I saw to explain that this is not physically possible and that I would like them to please change what they have said. Or to say to someone who's like, well, my grandbaby was born addicted. I hear your concern. Tell me a little bit more about what you know about what was going on with your grandbaby when they were born. And is it okay if I tell you a little bit about medically what it sounds like was probably going on and that a baby can't be addicted? So substance use disorder, this is a really messy slide. It's got lots of things on it that you don't have to memorize or know, okay? Because the benefit for you is there are addiction specialists, family medicine, all kinds of providers who can help you define if someone has a substance use disorder. What I want you to take from this slide is that it takes multiple factors in what we used to call substance dependence and substance abuse that we are now calling substance use disorder. And it is regulated into a mild, moderate, or severe. This is one of those ASAM criterias. It's in your DSM. It's very accessible. There's even a checklist. Like if you were interested in looking through this, you can pull up the checklist and check box things for yourself or a family member or like a patient that you're caring for to help understand. It's also can help a patient understand why was it defined as a substance use disorder. So tolerance and withdrawal that we talked about earlier, they alone do not imply a disorder. You have to have some loss of control, as well as some of that physiology and some consequences. You have to have all three things together. Back to the way we talk about things. I learned early in life as a PA that I would never be a doctor and that regularly people would call me doctor. And early on, it was a very uncomfortable thing for me because I wasn't a doctor and I was trained to very much and quickly, for medical legal reasons, clarify my licensure. Interestingly, as the years progress, and I have progressed in my confidence of myself, in all honesty, and my ability, as one of my street outreach team members taught me once, to brag about myself, because when we brag about ourselves and what we do, we're also bragging about the people that we care for. I learned that the PA after my name is now the reason I argue what I am is because I want you to know that I'm a PA, not because I'm not a doctor, but because I'm proud of who I am and what I do. And that there's a lot more to it. So I give you that who I am slide, and I have to tell you, because this is one of those medical lectures, who I am by licensure in the letters, but the letters after my name are not what define me. My she, her pronouns define me. The fact that I'm a mother and I'm a daughter, I'm an only child, I'm Latina. Those are the things that define me. And so helping individuals with substance use disorders identify who they are by using the diction of addiction is really a great place to go. So when we talk about somebody and say they're an addict, it's not who defines who they are. That's the disease they have as a substance use disorder. This is an individual with an opioid use disorder. This is also an individual who's a mother or who's pregnant or who's been incarcerated or who's currently unhoused, has a master's degree. Defining who person first language is with anything is really important. And honestly, using their name, or if you don't know their name, asking what someone's name is really the best thing you can do. Because I'm sure all of us have had an experience where somebody can't remember our name and remembers everybody else's, and it always doesn't feel very great. Urines are a really important place that I talk about use of language, but also if somebody is currently actively using a substance, clean and dirty doesn't define a person. Using positive or negative for a test result, using as expected or not as expected. Because for me, if you ask me about a test result, whether it's urine or blood or whatever sample we're receiving, in my medical world, it's all dirty. I put on a pair of gloves to take anybody's urine sample. It doesn't matter what the answer is to the urine. This one's actually my favorite one, and we have it laminated in a lot of places, talking about places that we kind of technically can and can't use language because people understand the language. And these are very accessible for free. They'll even send you the posters. When we're talking about somebody who's on medication for their opioid use disorder or their stimulant use disorder, that it's pharmacotherapy, just like if you have diabetes. It's not medicated assisted treatment. It's a piece of their treatment. And then using strength-based languages with individuals, because you'll have patients all the time who say, I'm an addict, I'm dirty, I'm weak. Helping them find strength-based words just simply by referring back to them, utilizing them. The one I honestly struggle with the most is the word manipulative, which is a deficit-based word. And instead of talking about individuals who are manipulative or being manipulative, that they're resourceful. Because this is someone who's trying everything they can to get at what they believe is what they need. Ultimately, the biggest challenge with this disease is particularly in the perinatal period with pregnant and postpartum women is the discrimination and the stigma. And no one is stigmatizing themselves more than that individual who currently is pregnant or recently had a child and has faced the consequences of the disease that has affected their brain. And this is just a list of committee opinion recommendations for governing principles when we're working with individuals who may have higher levels of discrimination and stigma, but really working towards prevention. For those of us working in substance use disorder, we are often not lucky enough to be around for the prevention window, so we're already at the treatment and the access to services. Really respecting a patient's autonomy. We can provide all the information in the world. We don't have to make the choice or live with it, but helping a patient navigate what they find is most important or they can do. Providing that comprehensive care, which is what our team really tries to do, and I empower you to do. The less places someone has to go, the more likely we would be successful, right? I don't know about you all, but many of you probably work kind of an 8 to 5 weekday kind of job, and it's near impossible to get yourself to the dentist or to go get your mammogram or see your healthcare providers or anything because we work the same hours as the people we are trying to access care from. And then safeguarding against that discrimination and stigmatization, which the biggest thing is recognizing that we don't know what we don't know. We don't know what this individual has faced. We don't know the trauma they've faced, both inside and outside of the healthcare system. We don't know the discrimination they've had. We also don't know who they are, and we probably don't know a lot about what they've been going through. My best opportunity to educate myself is when a patient says something to me and I'm brave enough to be like, I'm going to need you to back up and give me a little more explanation because I'm going to admit to you, I have no idea what that is. And I have no idea what it's like to walk in your shoes. And if sometimes I'm educated that I've used a wrong term or something that made someone feel really uncomfortable, the opportunity to sit down with that individual and talk through that and apologize, but also say, can you help me with what I should have said? What could have made this situation better? That recognition and prevention is really important, and screening is where that all starts. American College of Obstetrics and Gynecology does state that we should screen all pregnant women for substance use disorders, just like we screen for depression. And there's a bunch of different ways to screen. And where you work probably dictates how you screen. We use the NIDA quick screen here at the university. But there are articles galore out there talking about how we can do this. That 5 self-report screening instrument, which is the NIDA that we use, and how important it is in public health. Many of you on here are probably researchers. We, like myself, we need the numbers, right? That's how we continue to care for people, is to be able to explain what the numbers are. So that ability to screen also helps us have the data, which helps us to prove the need. It's also proven that that self-reporting is more important. So if we can sit in front of a person and ask the questions, they're less likely to be answered truthfully than if we can provide the screening tool to be filled out even before they come in the door. Screening, brief intervention, and referral to treatment is the level at which many of us are at, that SBIRT. Okay. Screening is not based on risk factors. If you are truly screening, that means you are asking everyone. So this is not the patient that comes in the door or the client that comes in the door or the student that comes onto campus to talk to the counseling center and says, yeah, I have this going on in my life. And, well, I used to have a boyfriend that drank a lot. And as they start to talk to you, you think, oh, we should probably screen for substance use. That is not a screening tool. The screening tool is this person is here now, and every person gets this. So that's why I said the American College of Obstetrics and Gynecology recommends that every pregnant patient on their first visit receives a screening tool for substance use disorders. Here you can see that NIDA.
Jasmine, can I ask you a question?
Please do, Janelle.
About the screening.
Yes.
So you mentioned that they are more likely to report honestly in a screener versus you asking that question. Could you elaborate a little bit on that and the reasons why you're thinking that happens?
We believe from, and there's data out there to say that no matter what the question, it's and the example that's actually been used is in alcohol use. How many drinks a day? And if I ask how many drinks a day or a week directly to a friend, a family member, or a patient in a professional setting, what has been found is that it is a quarter to a half lower than what is actually being consumed. Whereas when provided the opportunity to not have to face answer that question, you are not as afraid. Mind you, we're still going to check, right? You think about when we do a survey and it's like, yeah, it's average. And you're like, I actually hated that place. I didn't want to eat there, but it was average. It's that's where the evidence comes from. And then when you have the screener and are able to sit with the patient and say, hey, I noticed that you did check the box that you're having a drink a day. Are you concerned about that? Do you want to talk about that? That's a little bit more about that brief intervention, that like, how much of a risk do we have? Also, how open are you to having the conversation? And if the patient says, I don't think it's a problem, great. Know that this is a place that if you were concerned about your drinking or concerned about someone you knew's drinking, we're a safe place to come and ask for those resources.
Great, thank you.
Yeah, no worries. There's also the craft questions. A lot of places don't use the craft questions because they're not working directly with adolescents because you have to be under 26 years old for those. I enjoy them here and we do keep them around in case we have teens in the office because I find NIDA to be a little bit daunting at the younger age. But you've got many tested and trusted screening opportunities that are free. So we do use the NIDA. It is not you don't have to pay for it. You can have them fill it out online, or we have a paper copy as well if somebody's more comfortable with pen and paper. And like Janelle was asking on the difference between asking the questions and having them write the questions down, the biggest thing and the biggest question you can ask is if it's okay to talk about it. Hey, you filled out the screening questionnaire before you came into the office. Are you okay if we go over it together? Is it all right if we talk a little bit more about your nicotine use? And sometimes I even ask even more of an open-ended question of, is there anything that you filled out on a questionnaire today that you'd like to explore further? And if someone says no, that's okay. It's all in, again, the language and the response that you give of, great, thanks for letting me ask. Let me know in the future if you ever have questions about that. I talk a little bit about drug testing because there's a million ways to test. You can pee in the cup, and even there's 3 or 4 different testing modalities that are rapid or long-term outcomes, hair samples, blood draws. Now for alcohol, there's even a brace that looks a little bit like like the devices you wear for home incarceration, that actually is testing your sweat levels to see if there's alcohol there. And false drug testing in this country has cost many moms their children because of a lack of understanding of the drug testing or the drug testing actually being a false positive. So when we talk specifically about urine toxicologies, we actually did a study at the U and a couple of other Utah institutions looking at family medicine physicians and toxicologies. And we were looking at 5 out of 7 questions being answered correctly. 20% of the individuals answered more than 50% of the questions correctly. What this told us, particularly at the university where we train all of our family medicine physicians and OBGYNs who are on the inpatient floor, how to read the toxicology results, that we still don't fully understand toxicology results. And so asking someone to double check that the results you have in hand is read correctly, and if there should be further testing is really important. So the example I use is for us in clinic, we utilize a point of care cup. And I usually have one, but I don't have one with me. It's literally, you pee in the cup and the little screen comes across and you get one line means it's negative. If the second line shows up, that means the substance is present. That is a point of care test that has high rates of false positives. It cannot be used in a court of law. It cannot be used as a confirmatory test. It has to go to microscopy from there. So we have to order a second test that gives me a quant, a number that goes to the lab. They look at it under the microscope. I am so far from a microscope human being that can look at like pathology. I'm not great at those things, but I know when the result comes back, that's my confirmatory test. I say all of this to say none of us really know what drug screens read, and they're all different. And even for us, we use very specific ones here because that's what insurance covers, that's what's available. When I see someone from another institution, I have to go back and do some research to really understand what toxicologies they were doing. They shouldn't be used punitively. They should be used for education and support purposes. All of these articles just kind of point out the systemic racism based on this disease over the years. We had the quote, the crack epidemic. Now we're in our opioid epidemic. And we talked a lot about cocaine kids. And that was primarily in our African American population in this country because that's who got singled out in the media. This disease is a disease that does not pick and choose a race, an ethnicity, a gender, or a socioeconomic status. It affects all of us. I know that for all of you who are on this call right now, you probably know at least one person who's pretty close to you who has struggled with this disease, if not more, or if not yourself. And know that you are seen and you are heard and there is support out there. It's not a moral failure. The Washington Post headline here, this crack baby's the worst threat is mom herself. All the way to this not very long ago produced article again in the Washington Post, children of the opioid epidemic. So let's talk about women specifically, because we are talking about reproductive health care. And I use the word woman because that's the other challenging thing in medicine is that the substance use diagnoses are very much related to your XX or your XY chromosome. So we go all the way back to chromosome basis. So things we know for sure related to women is that they often move faster from their first use than men to addictive changes in their brains, which is known as telescoping. It is often earlier in life and most commonly initiated with a sexual partner. There are some external factors that add to this. Many 36% of women versus 7% of men are using a substance in order to trigger weight loss. And that's where they start with that substance. And then it triggers the brain to start the substance use disorder. And 52% of women in comparison to 38% of men, it's in order to get increase in energy. And this is specifically looking at our methamphetamines and our stimulants. We also know that women are more likely to not just initiate with a sexual partner, but to have the sexual partner who controls the quantity and how the drugs are used. I take care of a lot of women who come to see me who cannot quantify how much they've been using, can't quantify how they're getting their substances other than to say from a partner, and also don't know how to safely manage their own use disorder if that individual is not around because they don't know how to safe inject because somebody else has been injecting their drugs, or how to prepare it in order to smoke it. We've got to look at it, particularly when working with women, from a trauma-informed understanding. 55% of individuals that are women with a substance use disorder have a history of childhood abuse or neglect, with 65% of them having ACEs scores higher than 4. We look at high rates of intimate partner violence. There was a study known as PROMO, which is a big national study looking at substance use disorder specifically in women. They said 10% of those women admitted to sexual abuse by a partner, and 31% of them had financial abuse. And not uncommon in both men and women, but a little more defined and understood in women, is this high rate of mental health disorders, depression, anxiety, PTSD, and then we can break it down further for eating disorders, bipolar disorders, personality disorders. So self-medicating. If we go to the pregnancy piece, which is what many of you are here for to hear from me today, we are looking at a among the general population, about 50% of pregnancies are unintended. So that is unplanned, or we weren't preventing a pregnancy, but we weren't really ready for a pregnancy. That's our general population. Everybody in the United States, 50% of pregnancies. And this data is back from a journal article put out in 2017. In individuals with opioid use disorder, 86%, so almost 9 out of 10, had an unintended pregnancy. So 34% of those women said it was mistimed. So those were the individuals who said, well, we did want to have a baby, but this wasn't right where we were planning it. 27% unwanted. So individuals who had no desire to be pregnant at the time. And 26% who just didn't feel like yes or no either way. So to continue on talking about opioids in pregnancy, and I will say that most of the data that is out there is surrounding opioid use disorder, both because of the opioid epidemic, but because there is medication to help support opioid use disorder, and so it's a little harder, easier to study. 1 in 5 pregnant women who are receiving an opioid prescription in pregnancy. So if we take 5 pregnant women who come in, anybody, not with a use disorder, just 5 in general, 1 of those 5 in their pregnancy will be prescribed an opiate pain medication, for the primary reason being some form of pain, and primarily coming from an OBGYN or a family medicine provider. The hard thing to really narrow down is how many individuals' opioid use disorder started with prescription pain medication. Dr. Smith and I can tell you here that it's probably over 50% of our patients who at some point in time had an opioid prescription for pain, whether that be post-surgical or many of them pregnancy-related or menstruation-related pain, who then had continuing ongoing use of opioids that eventually can be defined as an opioid use disorder. And I always like to talk about us here at home, specifically in Utah. And unfortunately, there are many things that we are proud of that we have as a state. And then there are a couple things we don't want to be so proud of. But we are the #1 prescriber of opioid pain medications to pregnant and postpartum women who are on state-assisted insurance, so on Medicaid. So the root of the problem is also coming directly from healthcare offices, where people are also coming to ask for help and support. This map here gives you a little bit of look at opioid use in pregnancy. The darker the color, the higher the use, over 30%. The white states we did not have data on, so they're not actually counted in the continuing. And then this is that statistic that we talked about for Medicaid. Here are your top 5 reasons it's prescribed: abdominal pain, lower back pain, headache, joint pain, and migraines. The map on the left is a similar, but from a different study and different, it's 2 years later, looking at opioid use during pregnancy. And the map on your right is from the Journal of Internal Medicine, looking at trends in opioids and psychotropic medications in pregnancy from 2001 to 2015 in the privately insured population. So our left map, the dark map, is looking at Medicaid specifically. Our right map is looking at privately insured. The more red, the higher the prescriptions. So privately insured, 14% were prescribed. 6% were getting a psychotropic, and 3% were getting both. So one of those scary things is that rates of pregnancy complicated by opioid use disorder quadrupled between 1999 and 2014, which is probably not surprising to all of you who are now working on living through the opioid crisis. It has gotten worse since then. We saw an increase from 0.4 in 1,000 births in 1999 to 3.7 per 1,000 in 2014. And in 2010 specifically, 6.8% of our neonates were positive for substances on their cord. So we are part of what's a cord study where we take all cords, they're de-identified and they're tested for substances. And it's been done multiple times over several years. But in the 2010 sample showed 6.8% of those neonates born in Utah hospitals to be positive for opioids. Now, the challenge we have there is some of them are prescription, right? And some of them are illicit, and that's not broken down. It's just simply that there are opioids in the system. Ultimately, just trying to drive home that it's a problem. And I know we're all dealing with it in our different ways and in the different things we do, whether we're taking care of children who are born into families with opioid use disorders, or whether we're taking care of mamas or families. And at this day and age, also even like college students, high school students. So if we look at methamphetamine, because that is the other substance most commonly co-occurring use here in Utah, 0.2% of deliveries between 04 and 15 were affected by amphetamines. And if we look at our rural counties, which many of you may be in, 5.2% in our highest use areas. So from 1 to 5.2%. And your graph on the right gives you the national trends in amphetamine and opioid use. Now, why do we care and what can we do? The big thing here is that pregnancy is an opportunity, okay? 80% of women who are pregnant and have a substance use disorder will obtain recovery with or without the support of people like you and I. 80%, my friends. That's a big number. 8 out of 10, 80 out of 100. With intervention, we can probably increase that number, right? But remember, we're just talking about pregnancy here. We're not talking about postpartum.
Jasmine, there's a question do you have current numbers for your previous slide?
For the cord toxes?
I believe so. That's what she was asking now.
That is our most recent cord tox review. There is another one currently under review, but it has not been published yet.
Okay, thank you.
Yeah. Dr. Bouchai and then Dr. Smith has now joined that team as well. They try to do the cord toxes every somewhere between 5 and 8 years. It's really expensive because they're de-identified. So it's actually really hard to get hospitals to buy in and get them collected, but we're working on it. 80% of women who were abstinent in the last month of pregnancy returned to use with at least one substance in the year postpartum. So like I was talking about, our biggest problem is that postpartum window. That's where our risk lies. And that is really driven with our overdose deaths. So this is the general trend of opioid overdose. But what I'm really wanting us to get to, and we're running out of time and I want to be able to do questions, so I'm just going to get through these couple of things. This is men and women overdose numbers in the country. And if Leo, you can also post these slides. Like if these slides are able to be available to people, you can share our slides. We're happy to do that because all of the articles are on here. So
I can share them for sure, and they'll be posted on the Canvas page, and we've been dropping them in the chat as well. So hopefully our participants have access to those.
Fantastic.
And also, you can take your time too. It's okay. You can still talk about what you want to talk about as well. You don't have to. It's okay if we go past it. Okay.
Okay.
Just wanted to make it known.
I just want to make sure we get some of this in, and then we can do what did people want to know. So, and so this is, if we're asking for the most recent data that we have here in Utah, this is hot off the press last year data from our MMRC, which is our Maternal Morbidity and Mortality Committee, which is why Dr. Smith can't be with us today because we usually lecture together, but she is currently the head of our MMRC and they meet every month, and today and right now is the time they meet. So she's at that meeting. But the leading contributing factor for maternal deaths in the state of Utah is substance use disorders and overdose. Looking at both pregnancy and birth and postpartum. And those top 4 causes here in Utah, 25% were accidentally drug related. So those could be individuals who had any form of an overdose. They could have gone home with a prescription and taken too many of them together. It could be somebody who has an illicit use and was in recovery and has a decrease in their dependency, and therefore a smaller amount of substance led to overdose, or they didn't know what was in their substance because currently our opioids are methamphetamine, everything's laced with everything. 20% were suicide, 17.5% were an obstetric complication, so not related to suicide or substance use, and 15% were other medical conditions. That is a stark difference for suicide and accidental drug-related deaths. Individuals with a substance use disorder, as we talked about earlier, are their worst critics. And they put off their prenatal care because they are so afraid of the stigma that can be put there, putting them at risk for severe complications. And postpartum, if not continuing to access care, putting them at high risk based on postpartum depression, stress of raising a newborn if they've got a kiddo at home. Loss of a child is one of the main reasons for suicide and return to use. This was another article written by Dr. Smith and a couple of others of our providers at the university that just gives a nice, clear picture of that 26% of all deaths were drug-related. People ask about the drug-induced deaths. Some of them have tox screens, some of them don't. But you can see here the polysubstance use is about 83% of individuals. So they've got more than one substance in their system, with 66% of those individuals having 3 or more substances. Our most common in our state being opioids. Second most common being benzodiazepines, which Xanax, Valium, alprazolam. 34% is the others. Those are our synthetics. That number we are afraid to say is probably getting higher because we don't know what a lot of our substances anymore. That's the spice. Xylazine would fall into that category. And then we've got antidepressants, antihistamine, or amphetamines, muscle relaxers. Alcohol and Tylenol, interestingly, are shared there at 14%. Sedatives and hypnotics, cocaine, and cannabinoids. So our amphetamines is where you see our methamphetamines as well as prescription amphetamines for ADHD. This is just specifically looking at pregnancy-associated death in Utah and the contribution of drug-induced deaths and where they occur. We do know that the majority of them occur at 6 to 12 months postpartum, which many places don't even define as postpartum. But where we here as a team define as your 4th trimester and work really hard to keep people in care and in support for at least the first year postpartum. For any of you who've had direct experience with pregnancy care, you know that while you are pregnant, you are offered and usually seen a whole bunch by a healthcare provider. Those first few days right after delivery, you're probably in a hospital, or if you've had a home midwife, they're checking in, you've got somebody constantly working with you. That's 7 to 42 days after, you still have some postpartum support from your obstetrics team, and your baby, if you're raising them, is at the pediatrician a lot. So there's still a lot of point of contact. Once we get to that 43 days, it's really where we kind of cut off obstetric care and the definition of 8 weeks postpartum. And then from there, there's not a lot of support to be had. These numbers are from 2005 to 2014, and we looked at 136 women. I'm going to stop there. These next slides go specifically into like medications, things like that. I am happy to delve more if people have those questions, but what I would love to do is to be able to answer your questions, because that's what we also come here for. It's more important to me that you are getting what you feel like will help you.
Thank you, Jasmine. And we're gonna open it up now to kind of a Q&A session. So if you guys have any questions, you're definitely welcome to drop them in the chat, or you can raise your hand. I actually had a question. So I know we do talk like a lot about opioids and stuff when we do talk kind of about the numbers. And I saw that I know there's like okay, so in Utah, I know that like medical cannabis is legal, but does that have like any of like how does it really affect kind of how does that fit into the picture? I don't really know how to phrase the question, but like because we always talk about opioids and stuff, but how does like especially now that it's like medical and I guess it's like legal, but how would that kind of work?
So we categorize cannabinoid use disorder the same as we do other use disorders. If if you are on medical and have a medical card, we make sure that's in your chart. That's related to Child Protective Services piece. However, no matter what cannabis you're using or how you're using it, it gives us the same fetal risk. So because cannabis is legal in many places in this country and medically in even more places, we of course have more evidence as to risks for fetuses. And it's one of the few, along with alcohol, that we truly have numbers and data to say that there are risks to fetuses and risks to neonatal outcomes. And so we spend a lot of time, as I would encourage everyone to do, asking patients to abstain from marijuana use and just making sure that they have an understanding and that you've come to a common agreement. You're not excused from our practice. You're not welcome to be here if you're using marijuana. That doesn't help anybody, but it is a big conversation in your risks of preterm births, small babies. We see some learning risk outcomes in younger children, particularly that 0 to 3, and then that 4 to 8 year range if we're looking at pediatric outcomes. And so we have those conversations as well. But you are still, you're welcome. And particularly if you can express to us, you understand the risk and here's where we're at. The hyperemesis of cannabis use is one of the big problems too. People use a lot of cannabis and it actually induces this nausea and vomiting that is absolutely can't be stopped. And we work with a lot of patients who we have to admit for that. It's horrible. It's one of the worst withdrawal use syndromes we actually try and manage in patient. So yes, so cannabis does include that whole list of other substances. There's a lot of places that would say, well, it's cannabis, it's legal. Well, so is alcohol and so is nicotine. Both of those also have risks and outcomes.
Thank you. And I also had another question. I'm like full of them, but
Love it.
um so I know that like with substance use disorder there could be like co-occurring like maybe mental health disorders as well, such as like depression or anxiety. So let's say you're at like the super rad clinic. Do you guys provide kind of I guess those mental health services in conjunction to the substance use kind of disorder services that you provide, or is it kind of a separate clinic, or how does that work?
Yeah, we call ourselves obichiatrists here at the Super Rad Clinic, and we do provide mental health support in addition to the challenge being, as many of you probably face, Medicaid has very specific restrictions on who can and cannot provide specifically therapeutic like mental health care. That we have done a workaround with that specifically that's why we have a social worker on staff who can do crisis management and initial therapeutic management while we're working to get you in with someone who your insurance covers. And then at every half day of Super Rad, we have a third or fourth year psychiatric resident or triple board resident. Those triple board residents are being trained in pediatric and adult psychiatry as well as to be pediatricians. One of them are here with us who have their attending directly available on the phone, who are providing most of our medication management in supervision with us, who have all gone through a handful of extra lectures and then just now years of doing it, as well as utilizing their attending, whoever's supervising them from their program.
Hey, thank you for that answer. You're really good at answering all my questions. You're so knowledgeable. I
Oh,
love it.
thank you.
And then I see that Janelle has her hand up. So, Janelle.
Yeah. I'm wondering, I mean, your guys' Super Rad Clinic is well known and you guys provide amazing resources and information. What if you are not within the Wasatch Front? Do you guys have or no recommendations for other clinics that throughout the state of Utah that are similar to yours?
So we are happy to say you've got a couple of options now. We used to say we're the only, we're not the first. There is the PATH program that is run through McCady Hospital and the Intermountain Hospital System. They are a consultation service. So Dr. Terry Kurtz, who is an OBGYN by licensure and then did the addiction fellowship and came through residency and fellowship with our team, is the consulting physician on that team who also has peer support and care management, you are managed by a community obstetrician, and then she does that consultative specialty care. So that is one option. That gives you kind of Davis-Weber County support because it's very localized, kind of to that McCady area. In hopes, in all honesty, they are a startup program also on opioid settlement funding. We're hoping to be able to prove the numbers to be able to expand that through the Intermountain system. And then your secondary option is ultimately stemming back to super rad. So we do around 25% of our care virtually. And we take care of women in Moab, in Delta. Between Dr. Smith and I, we are licensed in Idaho, Nevada, Wyoming, Montana, Colorado. So we see women from all of the surrounding states who may not have other access to services, who are seeing a family practitioner who manages their pregnancy or an OBGYN who's managing their pregnancy. And then we provide that substance use piece of things. All the way down to the catchment of if you're someone who your insurance is not going to make it possible to see us, we will consult with your provider team to help make sure that person is cared for and is accessing what they need. And then your kind of third or fourth option, if in the greater area and near one of the community health centers, we train all of their fellows through our program as well and work hand in hand with them to work with our patients who may not be able to access insurance care, because that is one of the university challenges, right? If you cannot get insurance, we are not cheap. And so we will also work directly with CHCs to get you connected to a CHC provider who we know has had some training and who also has direct access to Dr. Smith and Emily and myself and our care team.
Great, thank you.
Yeah.
And I'm just going to open it up just for a few more seconds for any questions. And I did just want to say thank you so much for taking the time out of your day to give such a really insightful and knowledgeable presentation. I really, really appreciated it. And I also really, really liked how you said that infants cannot have an addiction. I really like how you spoke on that because they can't. I mean, it's a physical dependence, but infants just cannot have an addiction. So I really appreciate you saying that.
Thank you. I have put in the chat, my friends, the best way to contact us. That cell phone number can be texted or called. It is primarily carried by Shauna Filion, my lead care coordinator, who's now our program administrator. She's got a title change. We call her Mama Shauna around here because that's what the patients started to call her. That number, any one of you could call with a question to talk to Dr. Smith and I. That number you could call with a client or a patient who needed some help or support or a family member. And that number you also could provide to someone who is looking for access to support and care, and they can text or directly call it as well. So it's a patient as well as a consultation line. It helps you not have to come through the navigation of the nurse line, the hospital line to get to us 5 steps down. This will get you directly to one of us. Technically, it's answered from 8 to 5, Monday through Friday, but Shauna checks it regularly. And if you had an emergent question, it's actually going to pop up with how to get to an on-call person who's technically one of our OBGYNs on call from the university. But if you are calling directly with something you need, once you get to a live human, they're still going to connect you to one of us. Because our goal for you all is that we, although provide an incredibly specialized service, we shouldn't have to be so specialized. Everybody can help and support someone right in the moment, and very few things are truly emergent. And we want you to have the confidence as well as the skills to be someone who's already sitting at this table, which means you have a lower level of stigma and bias. So I appreciate you for coming to the table already, but I also want you to know that there is so much room at the table. And we just want to be able to help and support you with helping and supporting yourself or anyone who needs support.
Okay, thank you for sharing that cell phone number. I have put it down in my notes too, and I'll make sure to share it with the participants today.
It's also
Um,
in the slides. Like if you open the slide,
eh,
the last slide tells you how to reach us. So
awesome. Thank you. And now I'll just hand the time over to Janelle, who will be presenting our case for today.
Great. So I'm going to share mine. And Jasmine, that was just amazing. I really appreciate it. And so my name's Janelle Preston. and I work in our up to 3 Part C early intervention program here in northern Utah. The case that I'm going to be talking about is a little girl that I've brought to the table before. She is now just a little bit older, and some other things that I have some questions on. So this is little Lily. She is currently 32 months old, and the main questions that we really have around her are this behavioral dysregulation, some developmental delays, as well as some caregiver stresses linked to an upcoming reunification with her mother. So Lily has been in the care of her maternal grandparents for really most of her life. They've provided the stable caregiving. She has a consistent routine with them. The mom has been incarcerated and is in the process of re-entering the home slowly, which is where that stress is coming up. She was prenatally exposed to methamphetamine and opioids. She was born at 36 weeks with a short NICU stay due to some feeding and irritability. But otherwise, her newborn course was uncomplicated. She does have some gross motor delays, which really are that unsteady running, difficulty with stairs, and limited jumping. She also, with fine motor, does struggle with some of the utensils and block stacking. She has about 10 to 15 words that she uses pretty inconsistently. And then her social emotional regulation is where we're starting to see some of the big stresses and concerns. She does have those tantrums that last about 10 to 15 minutes, or sometimes even up to 45 minutes to an hour, which are kind of really having grandparents have the struggle, and they are having difficulty with calming her down. So our goals, this is a lot of words on this slide that you guys probably can't read that. So again, it is really on the grandparents are really concerned about the intensity of her tantrums. They're not brief. Grandparents report that it's not a typical toddler tantrum, that really they're hard to interrupt. She can't regulate herself. And really are unsure of how to support her. They are wondering, because somebody in the past has talked to them about that due to her exposure in utero or prenatal, that sometimes that causes regulation issues long term. And they're also wondering if their stress level of having the mom come back into the home is also a reason of why these behaviors are happening. Last time I presented this case, one of the strategies that you guys all provided were some visual supports. And the family really tried some of those visual supports, but they just report that they are not working and wonder if they're too advanced. And she doesn't have the level of joint attention yet. So my questions that I'd love some ideas and support around are, what are some additional strategies or supports that could help Lily's increasing tantrums and emotional regulation challenges? How can we, as an early intervention program and support from the community partners, help grandparents as they prepare for that reunification with the mom? And are there delays that, when delays span multiple domains alongside behavioral concerns, What indicators suggest it's time for a more comprehensive development? So should we be referring her to somewhere else? So
It's 1:28, so I don't know if we'd have time to share a bit of our ideas from the case presentation breakout rooms, but I did just want to remind everyone of our next session. It's going to happen on April 8th, and our presenter is going to be Ashley Yeager or Yager. I already forgot how to pronounce her last name. And she's going to talk to us about strengthening community partnerships and building strong coalitions within our communities. So I'm really excited for her. She's from one of the extension offices here up at the university, Utah State University. And I just also wanted to do a really quick case presentation plug. It's just a really great way to get some ideas in these breakout rooms. So if you do have a case that you're working on that's a bit difficult, you can always just contact Project Scope at usu.edu and you can submit that case through there. And I also want to remind everyone about our Canvas page where you can access all of those resources that Jasmine had for us today in her presentation. If you'd like an invite to that Canvas page, you can email Project Scope at usu.edu and we can send that invite over to you. So thank you guys.